to the Clinical Pathological Conference, CPC, organized by Ophthalmology Department. So the title for today is a greedy bug when one room is not enough. What bug is it? Later we'll find out. So to introduce myself, I'm Dr. Lam from Ophthalmology Department. We are very honored to have our list of panel discussions. We have Dr. Khairul Najmi from Gastroenterologi and Hepatology Unit of Medicine Faculty, Medicine Department. We also have Prof. Petrick from Infectious Disease Unit of Medicine Department. We also have Dr. Intan Bazilah from Radiology Departments. So without further ado, I think we should start as soon as possible. So without further ado, I would like to invite Dr. Lee Jing to present on the case. Thank you.
Hello, morning everyone. I'm Lee Jing here, medical officer from Department of Ophthalmology. I will start off our conference today with a case presentation. So our patient name is Mr. M. He is a 55 years old Chinese gentleman. He presented to us with the chief complaint of painful right eye, worsening for the past 1 week. For the history of presenting illness, he described the right eye pain is the nature is acute and sudden in onset. The pain is persistent and sharp, with a pain score of 8/10. The pain radiated to the right side of the head. It gets worse with the eye movement. It gets better with eye rest and oral analgesia. Despite from that, he also complained of the redness over the right eye, swollen eyelids, whitey discharge over the right eye, with the worsening blurring of vision. He had total 3 visits to the same general practitioner for his right painful eye. The first visit was during his day 3 of illness, in which he was prescribed with antibiotic eye drops, oral antibiotics and oral analgesia. During that time, he able to read bigger letters in his phone. However, his vision getting worse. He visited the general practitioner again during day 5 of weakness. During that time, he only able to visualize object movement. He went back home with artificial teardrops and some oral steroids. During day 7 of illness, he went to the same general practitioner again. During that time, the doctor noticed he only able to perceive some light over the right eye. He was advised to go to the hospital for further management. Additional history, he complained that he had fever, chills and rigors 1 week prior to his painful right eye. The documented temperature was 38 degrees Celsius. During that time, he visited another general practitioner. He was given paracetamol and a week course of antibiotics, and the fever resolved in 2 days' time. Other relevant negative ocular history, he had no trauma to his right eye, no foreign body, no history of insect bite, no prior surgery done. He's not wearing any contact lens, and he never taken any over-counter eye drops. Other relevant negative systemic history, he has no runny nose, no cough, no shortness of breath, no abdominal pain or diarrhea, no hematuria or dysuria, no loss of weight, loss of appetite, no tuberculosis illness contact, no night sweats, no reason travel, jungle trekking or swimming. He has no pet at home, and he denied any high-risk behavior. For relevant past ocular history, he claimed that his both eye vision was good pre-morbidly. He is not wearing any glasses. He had no history of ocular trauma or surgery. He denied any medical illness. However, he never had any medical checkup prior to this. Family history, he is a single man, staying in trust with the father. He denied any family history of ocular malignancy or blindness. He is a plumber, and he smoked 18 pack years. He does not consume any alcohol or any recreational drug. This is a list of medication that was prescribed by the general practitioner during his painful right eye. We can see here there's a list of topicals, antibiotics, and also some oral analgesia and oral antihistamine. Chloramphenicol ointment over the right eye, gentamicin eye drop, which is a topical antibiotics over the right eye, Tears natural eye drops, and Norgesic analgesia, Piriton 4 mg TDS, Papace, and oral prednisolone 10 mg BD. He denied any drugs or food allergy. For the vaccination history, he had 2 doses of COVID-19 vaccinations was given, and the latest dose was 3 months prior his painful right eye. In summary, from the history, Mr. M, a 55 years old Chinese gentleman with no medical illness, he presented to us with worsening persistent right sharp pain for the past 1 week, associated with eye redness, lid swelling, blurring of visions, whitey discharge, and history of fever. During presentation, the ocular examination revealed that his right eye unable to perceive any light at all, with a very significant relative afferent pupillary defect, grade 5. He unable to move his right eye, and he is in pain. He was in pain that time. For the left eye, the visual acuity was 6.9, and the extraocular muscle movement was normal. This is an anterior segment photo of the right eye during presentation. As we can see, the lid was swollen and is red. The conjunctiva was injected and was chemosed. The cornea was hazy, and in the anterior chamber, there was presence of fibrin clump covering the pupil. So this is a table summarizing the anterior segment findings during presentation. For the right eye, the eyelid was swollen, red, with mechanical ptosis. The conjunctiva was injected and chemosed. His right eye cornea is swollen, hazy, with the fine keratotic precipitates over the endothelium. The anterior chamber of the right eye was shallow, with presence of fibrinous reactions. There was no hypopyoncene. There was no iris nodules, no peripheral anterior synechiae. The right eye pupil is 3 mm, however, is not reactive. Fibrin clump covering the pupil with seclusial pupillae. The lens was cataractous with a normal intraocular pressure of 15. The left eye finding was anterior segment finding of the left eye was normal. The eyelid was clean, the conjunctiva is white, the cornea is clear. The anterior chamber is deep with no anterior chamber reactions. The iris was normal, the pupil was reactive 2 mm. The lens was cataractous, the intraocular pressure was 12. So this table summarizing the posterior segment findings of both eyes. Due to the severe anterior chamber inflammation, the right eye, there was no fundus view over the right eye. For the left eye, the vitreous were clear with no vitreous hemorrhage. The optic disc was pink with cup to disc ratio of 0.3. There was no neovascularization over the disc. For his left eye macula, we found multiple hard exudates, presence of dot hemorrhages, and the macula was edematous. The peripheral retina showed severe dot hemorrhages in all 4 quadrants, with the presence of intraretinal microvascular abnormalities. The vessel was normal. In view of no fundus view over the right eye, we performed right eye ultrasound B scan. So as we can see here, for the right eye vitreous, it was full of opacities and loculations. The sclera was thickened, and there was presence of subtenon fluid. This is very highly suggestive of intraocular inflammation and infection. Systemic examination review. He was a medium build gentleman. He was alert, conscious at time, not septic looking, not tachypneic. His blood pressure was high, with the reading of 159 over 95 mm mercury. Pulse rate was not tachycardic, 85 beats per minute. He was afebrile with temperature of 36.2. His blood sugar dextrose was high, 80 mmol per liter. The cardiovascular examination review, no rhythm, no murmur. His lung examinations was normal as well, clear, equal entry bilaterally. Per abdominal examinations was soft, non-tender. The liver was 2 finger breath palpable. No splenomegaly. There was no auricular, clavicular, axillary, or inguinal lymph node palpable at that time. So at that point of time, we already come up with our provisional diagnosis. For his ocular diagnosis, he was diagnosed with right eye endogenous panophthalmitis for investigations. For his left eye, he had severe non-proliferative diabetic retinopathy with diabetic macular edema. Systematically, he was diagnosed with newly diagnosed diabetic mellitus, and in view of endogenous panophthalmitis, we have to rule out any occult infection. Endogenous panophthalmitis is an ocular emergency, so immediate action must be taken. For the right eye, we perform vitreous step, and we stem the vitreous fluid for culture and sensitivity, for both fungal and bacteria. For the right eye, at the same setting, we gave intravitreal broad-spectrum antibiotics. In this case, he was given vancomycin 2 mg in 0.1 ml, ceftazidime 2 mg in 0.1 ml. For topical antibiotics over the right eye, he was started on gut gentamicin 0.9% 2 hourly, gut ceftazidime 5% 2 hourly. Systematically, he was started on intravenous ceftriaxone 2 grams stat. Blood investigation review, there was presence of leukocytosis with a white cell count of 13.3, predominantly neutrophils. Pallor was thrombocytosis with a count of 513. Apart from that, the inflammatory marker was raised as well, with an ESR of 34, CRP of C-reactive protein of 11.1. Other blood investigation showed that his fasting blood sugar was deranged with a reading of 16.4. HbA1c was raised as well, 13.6. The important infective screening was done. VDIL showed that it was non-reactive. For the microbiology investigation, the right eye vitreous fluid shows significant presence of plus cell 4 plus count and also presence of gram-negative road 4 plus. There was no fungal element seen. Culture and sensitivity, there was presence of Klebsiella species, which is sensitive to augmentin and unacin. Blood culture and also urine culture and sensitivity show no growth after 5 days. Next, I would like to invite Dr. Intan, our radiologist, to give her input on patient radiological findings.
Okay, Assalamualaikum and good morning to everyone. I'm Dr. Intan, Urology Fellow in HKM. Okay, so for radiological investigation in this patient did CECT orbit on 4th of February 2021. So this is axial cut of CECT orbit in post-contrast and soft tissue window. Oh, cannot play. Okay. Oh, cannot. Again, sorry. Okay. Okay, so you can see okay, there is right eye proptosis. How to detect proptosis from CT scan? Basically, you draw a line in between of the zygomatic arch. We call as interzygomatic line. So you can see that the right eye is more protruded than what is usually expected. Okay, and then there's also presence of preseptal soft tissue thickening at the anterior part of the right eye globe. This is what we call as preseptal space. You can see that the space is thickened, and there's also presence of fluid collection within. Okay, this one, there's a fluid collection and also surrounding fat streakiness that suggests of inflammatory process that going on. And then you can see there's a thickening of the right orbital wall, right ocular wall, okay, as compared to the left side. And there's also presence of a surrounding fat streakiness with the involvement of the intracorneal fat space. Okay, and then if we go out a bit, Okay, there's a presence of air locules within the vitreous chamber of the right eye globe. And then if you look at the level of lens, okay, this is the lens. Okay, anterior to the lens, we call it as anterior chamber. And if you compare from the right side and on the left side, you can see that the anterior chamber is reduced. Anterior chamber space is reduced, which is complemented with what the eye finding has been presented before. Okay. Otherwise, the normal configuration of the right eye globe is still preserved. Okay, so this is the coronal view of the same patient. Okay, again, you can see there's a surrounding marked fat shrinking with thickening of the right ocular wall. Okay, and in coronal view, it's actually better if you want to look for the extraocular muscles and also the optic nerve. So in this patient, okay, you can see that the lateral rectus of the right extraocular muscle appears thickened and enhanced as compared to the left side. Otherwise, the rest of the extraocular muscle is preserved and the optic nerve is somehow still preserved. Okay, and if you look at the cavernous sinus, it still maintains its normal configuration and there's no evidence of thrombosis. And in the brain parenchyma, there's no enhancing lesion to suggest intracranial extension. And the left eye globe is actually normal. Okay. So our impression at this time is panophthalmitis of the right eye globe with preseptal and postseptal cellulitis. So this is the diagram, simplified diagram, just to show you what is how orbital infection looks like based on Chandler classification. So the first one is when the infection involves the preseptal space anterior to the orbital septum, we call it as preseptal cellulitis. When the infection occurred posterior to the orbital septum, we call it as postseptal cellulitis, or sometimes we call it as orbital cellulitis. When there's a frank pus at the subperiosteal region, we call it subperiosteal abscess. In type 4, when there's also frank pus involving the postseptal region. And in type 5, when there's already presence of cavernous sinus thrombosis. So another possible differential is endophthalmitis, in which the infection occurred involving the right the eye globe, but the infection is usually limited by the sclera. But in panophthalmitis, it is infection, it's a severe form of the eye globe infection, with there's be more extensive surrounding inflammation and edema, like in this case. Okay, so this patient also did ultrasound abdomen on the next day, in which the indication is to look for occult infection or source of infection for this patient. So we see that there's a presence of ill-defined heterogeneously hypoacute lesion at segment 2 of liver, measures about 2.4 times 2.8 cm. And there's absence of calcification or intralesional vascularity. The rest of the liver is homogeneous and there's no other focal lesion seen. Okay, so our impression, of course, tally with the clinic finding as patient count with sort of like sepsis. Impression is liver abscess because the margin of the lesion is ill-defined and there's absence of vascularity. And differential diagnosis, of course, you need to think of other possible liver mass. First is hepatoma. But usually in hepatoma, the margin will be more well-defined and there's usually there's presence of vascularity within. Second is metastasis. The appearance can look like liver hepatoma, but usually is multiple in number. Third one is hemangioma is less likely because in sonography, appearance of hemangioma is usually homogeneous hyperechoic. Okay, and the last one is liver cyst, also less likely because cysts appear as well-defined anechoic lesion. And then unless the cystic lesion become infected, then the wall can become ill-defined, and usually we can see there's presence of internal debris within. Okay, right. So this is the follow-up ultrasound abdomen, which is 2 weeks after the initiation of antibiotic. You can see there's that the previous liver abscess is smaller in size, meaning that it is responding to the treatment. Okay, right. Thank you. I think that's all.
Thank you very much, Dr. Intan. So I'll continue my presentations with the management of the patient. So our current impressions correlating with the clinical findings and radiological findings. The impression was right eye Klebsiella endogenous panophthalmitis and orbital cellulitis complicated by pyogenic liver abscess. For the ocular management, for his right eye endogenous panophthalmitis, systematically he was given intravenous ceftriaxone 2 gram BD. The intravitreal and subtenon vancomycin and ceftazidime was given times 2 for 2 times. Unfortunately, his right eye condition deteriorated, and we had to perform eviscerations to prevent intracranial spray. Post-evisceration, we co-managed with OMFS team for ocular prosthesis later. For his left eye severe NPDR with DME, we performed prophylactic scattered pan-retinal photocoagulation and also focal laser for the diabetic macular edema. And we plan for intravitreal anti-VEGF later. For the systemic management for his pyogenic liver abscess, we co-managed with gastroenterology team. He was given IV ceftriaxone 2 gram BD for 2 weeks, followed by oral augmentin 625 mg DDS for another 4 weeks. Liver function test monitoring was done, and the repeated ultrasound showed resolved liver abscess. For his newly diagnosed diabetes, we co-managed with endocrine team. He was started on metformin 500 mg BD, subcutaneous atrapic 8 unit TDS, and insulatard 10 unit on night. We referred dietitian and diabetes educator, and he need a proper follow-up at nearby healthcare clinic. Next, I would like to invite Dr. Khairul, our consultant physician, gastroenterologist and hepatologist, to deliver his talk on management of liver abscess.
Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. So just going to briefly talk on the management of liver abscess in this case. So in terms of liver abscess, two most common or two most predominant causes. Number one is pyogenic liver abscess, which usually caused by a bacteria. And then number two is amoebic liver abscess caused by Entamoeba histolytica, which is quite common in certain area of the world, for example, in India. And the rest, very rare causes include, for example, fungal or atypical organism, including a mycobacterium. So I will be focusing more on pyogenic liver abscess. Treatment approach is quite simple, straightforward. The main stay of the treatment is antibiotic. So need to start early in suspected or confirmed liver abscess. In terms of further combination treatment, it depends on the numbers and also size of the liver abscess. If it's less than 5 centimeter, predominantly antibiotic alone, up to 6 weeks of duration. And then ideally we should reassess whether there's any evidence of improvement in terms of the size of the abscess. In the guideline, they advise probably 2 to 3 days of imaging. But in practice over here, we usually scan about 1 week after the initiation of antibiotic. And then if the size of the abscess is about 5 centimeter or more and unilocular, so it advised to go for drainage. The most common method of drainage is non-invasive way via percutaneous drainage. And again, we have to reassess about 1 week later. If the liver abscess is multilocular and very large with thick walls, and then evidence of intra-abdominal complication, for example, peritonitis or origin from the hepatobiliary disease, so patient might need a surgical approach in terms of draining the liver abscess. The main principle of empirical antibiotic therapy, number one, it should be started as soon as liver abscess is confirmed or suspected. But again, usually in septic patient, blood culture should be taken first before starting the antibiotic. And number two, monotherapy with antibiotic alone only can be considered in small abscesses. It needs to be combined with drainage in large abscess. And the initial antibiotic should be broad spectrum, and metronidazole should be added as well if we suspect any anaerobe or entamoeba histolytica. And again, the antibiotic should be modified according to the culture and sensitivity result, and also to the local resistant pattern. In terms of what type of microorganism in the pyogenic liver abscess, the commonest organism are gram-negative anaerobic bacilli, with two most common bacteria include E. coli and also Klebsiella pneumonia. And the rest can include gram-positive cocci, for example, Streptococcus, Staphylococcus. If the patient have this type of bacteria, we need to investigate. There might be a different or distant source of infection, for example, endocarditis. And other microorganisms include anaerobic bacilli, for example, Clostridium, Bacteroides. If we suspect patient have this type of microorganism, again, GI tract must be investigated as well, because it might be the source of infection. In terms of the antibiotic choice, among the option include third generation of cephalosporin. As in this case, patient was started on IV ceftriaxone. Other options include beta-lactamase inhibitor, penicillin plus aminoglycoside, plus minus metronidazole. Other options also include carbapenem, fluoroquinolone, and also vancomycin. How about complication and prognosis? Complication of liver abscess include the possibility of a rupture of the abscess and the spread of the infection to the nearby tissue, which leading to shock, multi-organ failure. There's also possibility of septic emboli, especially to the central nervous system. In the chronic liver abscess, it might lead to fistula formation, for example, between the liver and also the pleura. Extreme complications include formation of gas-forming liver abscess, which usually occur in 1 to 5% of the cases. If the patient harbored Klebsiella pneumonia or suspected Klebsiella, known complications include bacterial endophthalmitis, as in our case today. And there's also association with colorectal cancer. So usually if patient presented with liver abscess, we do a screening for CRC once patient has a resolved infection. In terms of prognosis, mortality rate varies according to the case series, but it can up to 50% of the cases, which poor prognosis factors include advanced age, immunocompromised, multiple comorbid, and also any presence of systemic complication. Surgical management are usually indicated if the abscess is not amenable to percutaneous drainage, if there is evidence of inadequate improvement despite antibiotic and percutaneous drainage, any evidence of rupture abscess which causing peritonitis, or if the abscess is large and multiple. And the way to drain surgically, either open or laparoscopic, and open can include either transperitoneal route or transpleural route. So bear with me about 5 minutes. I will walk through on our local data on a 14 years retrospective analysis on pyogenic liver abscess in HTM. We have 206 patients from 2004 up to 2017. In terms of the incident rate, for the first 6 years, the incident is quite low, ranging around 0.1 to 0.9, but it shoot up from 2010 onwards, with the highest incident is about 1.4 per 100,000 person year. In terms of the ethnicity, in our local data is quite common among Chinese and also Malay. In terms of comorbidity of the patient, nearly half of the patient have diabetes and hypertension. Clinical symptom, majority of them, more than 70%, presented to emergency with fever and abdominal pain. And from clinical examination, about 41% from them have hepatomegaly on physical examination. In terms of etiology of the liver abscess, majority of them we could not find the cause, so we label them as cryptogenic, but the rest mainly coming from the biliary tract groups. Most of them have some sort of biliary sepsis, whether it's cholangitis, secondary to the obstructing stone, or cholecystitis. And the rest include intra-abdominal cause, hematogenous cause, and also iatrogenic cause. In terms of the abscess characteristic, most of the location of the abscess is on the right lobe. As we know, on the right lobe of the liver, there's a lot of blood supply. In terms of the number of the abscess, slightly predominantly multiloculated as compared to solitary abscess. And then in terms of the size, most of the patients have abscess ranging around 5 to 10 centimeter, with the median abscess size about 7.2 centimeter. In terms of the culture, in terms of the positivity of the culture, when we compare between blood culture and pus culture, of course, the yield is slightly higher in the pus group. About 44% have a positive culture from the pus from the drainage, and about 33.5% from the blood culture. And in terms of mono versus polymicrobial, a majority of them has monomicrobial, which most likely coming from the gram-negative group. And among the microorganism, the most prevalent was Klebsiella species, followed by E. coli. In terms of complication, majority of them has sepsis, followed by pneumonia and peritonitis. And in this case series, we have 3 patients who've been complicated with endophthalmitis. So at the moment, we have 4 patients, including this one, with our current case. So last slide, in terms of clinical outcome, duration of hospitalization, most of the patients spend on average about 17 days in the hospital, with nearly 70% of them have a resolution of abscess, although about 28 of them defaulted follow-up, and about 5% of the cases relapse with another episode of liver abscess. And we have about nearly 5% of mortality rate in patients having pyogenic liver abscess in HTM. With that, I would like to thanks.
Thank you very much, Dr. Khairul. Next, I would like to invite Dr. Petrick, our consultant from infectious disease, to tell us more about Klebsiella sepsis and diabetes. Welcome, Dr. Petrick.
Okay. So you heard the interesting part, the one I'm going to bore you with microbiology. Yeah. Okay. So there's Klebsiella and there's Klebsiella. So this Klebsiella, probably you never heard of it, right? So I'm going to introduce you to a new Klebsiella. This Klebsiella, we call it the hypervirulent, the godfather, the mafia. Okay. It's called, short name is hypervirulent Klebsiella pneumonia. Okay. The majority of the Klebsiella you see in the hospital, we call it the classical Klebsiella. Okay, so I'm going to introduce you to a term called hypervirulent Klebsiella pneumonia. Okay, one is because it's more virulent than the classical, and usually how we going to differentiate it clinically and microbiology. That's what I'm going to introduce you. Most of the Klebsiella coming from the community, we think this is hypervirulent. It tends to attack the healthy patients or the diabetic patients. And it's very common in our area, Asia Pacific rim. Okay, and when you see a Klebsiella that frequently spread like the case that you just see, it makes you wonder whether we are dealing with a hypervirulent Klebsiella. And most of the time, we need to control the source, or else you'll spread easily. And Dr. Najmi has shown you the multiple sites that our own data showed, whether, from the brain to the lungs to the liver and the spleen. Okay. In Malaysia, it's very hard to differentiate using PCR genes to actually differentiate classical Klebsiella from the hypervirulent strain. Okay. So main issues is this capsule, which I'll talk a few slides later, and all the genes that is there. What happens is you can see a thick formation of secretion here called the hypermucous secretion. This is trouble for doctors to manage, right? Because it makes the antibiotic difficult to work. It makes when you do surgical drainage, when you do percutaneous drainage, the tubes get stuck. Okay, if you see things like that happening, you might be dealing with hypervirulent strain. When you give antibiotics and the patient has clinical failure in terms of therapy, this is all the reasons you're probably dealing with hypervirulent. Okay, so we go to the classical one, tends to have pneumonia, UTI, bacteremia in terms of presentation, whereas the hypervirulent strain, as you can see in this case, tend to have metastases all over the place, including endodermitis, liver abscess. So classical usually attack immunosuppressed patient, whereas the hypervirulent will attack even patients without diabetic, normal patients also. So they have this classical capsular strain called K1. K1 is, as you can later will find out, that it can produce all this viscous and protects the microorganism from antibiotics. So this is very notorious, K1. So unfortunately, hypervirulent has 93% of this. These are all cytopores. Cytopores are nasty. They go and take the host cell iron and give it to the microorganisms. Okay, that's their work. So you can see a lot of cytopores in the hypervirulent strain. So again, most of these hypervirulence are community, and most of the thing that we develop Klebsiella in the hospital are nosocomial. Unfortunately, we think a lot of hypervirulent strain around our area, Southeast Asia. Okay. So again, the same thing I want to show you. Community, Asia Pacific. Again, the hypervirulent, as you heard from the previous speaker, the classical, maybe there's a source from the biliary side. So always, when you're doing ultrasound, CT scan, look for a source in the biliary that you have to settle, or else the patient can have recurrence. But many of these community strain, they may not have a biliary source. Okay. And as mentioned, they tend to be multiple. Okay. And most of the, they tend not to carry a passenger around. This hypervirulent, they don't like to share space. They like to be on their own, whereas the classical one sometimes have co-infection. All right. So the boring bit of this thing is this diagnosis. Can we make a diagnosis? Unfortunately, we need PCR base to test these notorious genes. These IUCA genes, RMPA genes, and PEG genes, which I'll show you later. Right? But the easy method is, if you're interested, when you get a Klebsiella, you call up your microbiology and you ask them, can you do this positive string test? Okay. So when they have this microbiology plate in the lab, okay, and if the thing is very thick, you can actually use a metal, metal stick and just hold it up, and you just stick there. Like when you have a bad running nose and it's all mucoid, you can actually pull. The children will be playing with their mucus. That's how long it is. So anything more than 5 millimeter, you're dealing with a hypermucus secretion. So that's the non-proper way of diagnosing this hypervirulent. Okay. So again, all the troublemakers are here. The RMA genes. This is how we diagnose one by PCR method. Virulence, plasmid, IUC, all these things plus the capsule cause the secretion of all this hypermucosity. Now try to imagine antibiotic trying to enter here. They can't even halfway reach the organism. All the secretion, they need to go through the secretion. Okay, so that's causes the failure. Okay, just bear with me on the micro part. Okay, so this hypervirulent has all these virulin genes present on this large virulent plasmid. All these genes that I mentioned, and remember the capsular serotype, especially the K1. And they produce all this secretion and causes metastatic secretion. Okay, so this RMA gene It's a regulator of this polysaccharide synthesis, confers hypermucosity phenotype in most isolate. Same with the MAG-A genes. Okay, so these are the capsular polysaccharides. Okay, same thing that I mentioned, and it prevents the migration addition, and it disturbs the neutrophils as well. Okay, so this may explain why treatment fails. So it's not the antibiotics. Okay, it's the organism itself is making life very difficult for the antibiotic to work. All right. So some is the host. So this is the picture of the positive string test. Okay. So if you measure, it's more than 5 millimeter. Whereas the classical Klebsiella doesn't have these features. Okay. So although it's very difficult, it tends to be pan sensitive. Okay. As you can see, most antibiotic works. It's sensitive in the plate, but when you use it in real life, you might develop clinical failure. Okay. It's nothing to do with the antibiotic, but it's got to do with the organism itself. Okay, so this is important to know. So we important in surgical management, whether we need to go very early on to surgical deployment, not about issues of changing antibiotics. Okay, and then the second part is the control of diabetes, which is I need to talk to you about. All right. So you've been mentioned about the liver abscess. Just 1 or 2 slides on liver abscess. So management can be problematic. Your percutaneous drainage may have become clogged. You can imagine the mucosity of the one. So probably sometimes you need large bore catheters, or you need frequent flushing when you're dealing with this hypervirulent strain. The second part about the endodermitis, you can see our own local data. You can see the incidence of endodermitis, but questions for most ID physicians is when we have Klebsiella bacteremia patients, and this is a different opinion by a lot of ID physicians, whether we should refer all our Klebsiella bacteremia and trouble our ophthalmology colleagues in the ophthalmology department, right? Can you imagine all the referrals that we made, and this has been mixed thoughts by a lot of ID physicians whether all Klebsiella bacteremia needs to be referred to the ophthalmology. And if you look at the systemic review and incidence, the incidence at best is 5%. So 5%, you have to take it and leave it. 5% may be a big thing for some ID physician. We said, hey, we can't miss this 5%, right? And you need to count the cost effectiveness of actually referring everyone for Klebsiella. So it's still a big issue whether we need to refer everyone. But the incidence, as far as we know, is about 5%. That means for all Klebsiella, you can risk of getting eye involvement is around 5%. Okay, so important to know that. So do we have this hypervirulent strain in Malaysia? Yes, the answer is yes. Okay, these are all studies that have been done around the Southeast Asia and Malaysia. Patients, healthy individuals like you and me, hopefully, okay, unfortunately are colonized by this hypervirulent strain. Okay. So when you're immunosuppressed, or when there's translocation of bacteremia from your colon, or you take too many antibiotics, right, and you can actually have this translocation. Okay. Now the other part I'm tasked to talk to you is the association between diabetes and this Klebsiella. Okay. All right. So there are many types of liver abscess, as Dr. Najmi told you. Okay. But if you look at Klebsiella liver abscess compared to other polymicrobial liver abscess, the incidence is much higher, okay, in Klebsiella liver abscess compared to polymicrobial liver abscess. That's number one. And diabetes was more common in the community-acquired Klebsiella liver abscess compared to the nosocomial. So those patients in the community with diabetic, all right, and we have seen it countless times, multiple times, they tend to come in with Klebsiella liver abscess, okay. So this is another study that looked at 78 cases of the K1 Klebsiella liver abscess and 81 controls with non-Klebsiella liver abscess, and they found diabetes was actually 2 times higher in the K1 Klebsiella liver abscess. So unfortunately, the hypervirulent strain loves diabetes, diabetes loves the hypervirulent strain. So they are working, all right. So this is an independent risk factor, not only for the hypervirulent, but also for the classical liver abscess. So how does diabetes cause problem in terms of management of liver abscess? So hyperglycemia actually inhibits the chemotaxis and addition of leukocyte, which damage the functions of the intestinal barrier. So this intestinal flora, which is actually our gatekeepers at the intestinal, so this diabetes go and disturb them, okay, prevent addition of the leukocytes, right? So if you immunosuppress, your sugar is not good, or you're taking a lot of antibiotics, okay, and this will clear the intestinal flora and cause the risk of formation of liver abscess. So hyperglycemia would change the structure and function of the vascular intima, so that Klebsiella can be transferred to the blood and cause liver abscess, okay. Not only that, it will cause problem with your antibiotics itself, okay. So imagine you have diabetes, your humoral immunodisorders, you can lead to increased virulence of the microbiome itself. You cause your T lymphocyte response and neutrophil function to decrease, okay. Reduce antioxidant, reduce inflammation, cytokines, all these helpers, bodyguards, your protection all gone. And so again, you're not blaming the antibiotic. It's not because the antibiotic failed. Your support system also failed at the same time, because of the diabetes, right? So that's why it's very essential for the diabetes to be controlled. Again, these are all the inflammation bodyguards that's supposed to help you to clear the bacteria. Doesn't work well if your sugar is not well controlled. So part of the management, as you have seen this now, is actually very, very good diabetic control. It's part of the management for Klebsiella liver abscess, okay, especially Klebsiella liver abscess. All right. So if you don't do that, as you give antibiotics, as your sugar is not well controlled, the chance of metastatic complications is very high. So many of patients don't know they are diabetic until they appear in the hospital with metastatic liver abscess, and then they found out they are poorly controlled diabetic. Okay, so we have seen again this type of patients, all right, because the neutrophil doesn't work anymore because of the hyperglycemic state. Okay, so my final slide is the relapse. If you look at our own local data, it is consistent with the current literature that there is a 5% relapse rate. That means when you treat these patients, you're going to see them again, okay, in 5% of the time. And we've seen some Klebsiella occurring at least 4-5 times in the lifetime of the patients. We have seen this type of patient getting recurrent Klebsiella, and so that's something you need to worry and look after. Okay, thank you very much.
All right. So this is the last talk for the day. Thank you, thank you, Prof. Petrick. So we have already known the hypervirulence of Klebsiella. So we also known about liver abscess. Thank you to Dr. Khairul, Najmi. We also know the diagnostic image. Now we go back to the eye. So we will talk about a little bit more on the panophthalmitis or endophthalmitis. So as mentioned just now, Klebsiella species have emerged as a leading cause of the pyogenic liver abscess, especially in Asia, in this part of the country. Especially with this hypervirulence of Klebsiella, which is quite high incidence in the community, especially with the diabetic mellitus. So 11% of the endogenous endophthalmitis associated with Klebsiella pneumonia liver abscess, and this brings potentially devastating visual consequences. And therefore, a prompt diagnosis and treatments are very essential for better prognosis. So now we heard about endophthalmitis, we heard about panophthalmitis. What is actually the difference between these two terms? Okay, so to explain that better, we need to understand the anatomy of the eye. So when we mention of intraocular structures or whatsoever, it basically is whatever that envelope within the globes. So the globes are actually enveloped by sclera posteriorly and also the cornea anteriorly. I'm not sure whether you can see the cursor. Wait, Okay, so these are the sclera, and this is a cornea. So whatever within the cornea, this globes is called intraocular structure. So the intraocular structures basically comprise of your anterior chambers, your lens, your vitreous cavity, your retina, your choroids. So as opposed to intraorbital structures, okay, so intraorbital structures basically means whatever the content comprised within the orbital wall, so which comprise of your globes, your ocular muscles, your fat, optic nerve, and leads and so on. Okay. So endophthalmitis are basically means the infections or inflammations of the intraocular structures. Okay, so basically you have hypopyon, you have vitritis and so on. Panophthalmitis on the other side is basically means intraocular inflammations or infections, which means the infection actually has spread beyond the sclera. So patient usually will have very severe chemosis, very copious discharge. Apart from whatever that having in endophthalmitis, they also will be having very severe eyelid swelling and redness and so on. So basically, the panophthalmitis are more severe forms of the infections as opposed to endophthalmitis. And illustrated in this case, speaking of red eye, so we need to know how to identify these serious causes. Okay, so then we bring back to red eye a little bit, just so for the benefits of the medical students. So there are a lot of causes of red eyes. Okay, there are common causes which fairly not serious, like such as conjunctivitis, subconjunctival hemorrhage, corneal abrasion, blepharitis, or the Auditorium. There are also less common causes but more serious causes such as viral keratitis, uveitis, scleritis, ankle closure, glaucoma, chemical burn, and also endophthalmitis or panophthalmitis. These are actually more serious causes. And as illustrated in this case, patient has actually presented to the general practitioner for 3 times prior to the presentation to us. In a way, the general practitioner has actually failed to identify the serious causes, as these serious causes can actually potentially bring poorer visual prognosis, and therefore they need to refer to ophthalmology as urgent as possible. So how do we identify all these serious causes of red eye? So basically the red flag symptoms, if you had heard before, 3 symptoms: pain, usually is very acute and severe; loss of visions, especially very severe; and also redness. So all these 3 symptoms are basically the red flag symptoms. If you see something, patients complain to you with all these symptoms, you should actually refer to an ophthalmology. So it may potentially represent the ocular emergency. The ocular emergency that I mentioned over here could be the panophthalmitis, endophthalmitis, or ankle closure, glaucoma, and so on. So now we go back to endophthalmitis and panophthalmitis. Okay, so there are 2 types of endophthalmitis or panophthalmitis. It could be exogenous causes, which usually due to trauma or surgery or due to corneal ulcer and so on. And there also another type, which is endogenous endophthalmitis or panophthalmitis. Endogenous is the one that illustrated in this case, in which the infections are somewhere in the systemic. So the source is somewhere in the systemic. So as mentioned earlier on, Klebsiella pneumonia are one of the major causes of the endogenous endophthalmitis or panophthalmitis, and the major risk factors are basically due to immunocompromised or diabetes mellitus. So how do they come to the eye? Basically by hematogenous spread. The pathogen can be bacterial, fungal, or viral parasites, but as mentioned in this part of the country, usually it's Klebsiella pneumonia. So what are the investigations that can be done? Basically, we can do ultrasonography as illustrated in this case, so or what we call B scan. So this is to confirm the presence of the variable echoes in the vitreous. So basically show the vitreous opacity, vitritis, sometimes loculation. So loculation means abscess collections which has been well wore off. Okay. And then it also provide a baseline to compare, so we can actually monitor from time to time. And one important thing in these cases is to identify the pathogen, because in order to treat adequately, we need to know what is a pathogen and to give antibiotics adequately and precisely. So what we can do is basically vitreous stab, which we didn't really perform in this patient. Another one is aqueous stab and also vitreous stab. So in vitreous stab, basically we are aspirating the vitreous fluid with 23 gauge of needle for 0.2 to 0.4 cc, and this vitreous stab will be sent for all the investigations such as gram staining, potassium peroxide staining, culture on the blood alga, chocolate alga, subrod dextrose alga, and McConkey alga. In some of the vitreous sample, we will also send for PCR tests as well for virus and also fungus. So as mentioned earlier on, in endogenous endophthalmitis, it's very important to identify the systemic causes, the systemic infection. So blood and urine cultures are very important. If there's any visible infections ongoing, like in the skin, on the catheter tips, or on the abscess of the joints or whatsoever, then we can culture from the site as well. So as mentioned by Dr. Intan, neuroimagings are very important. So this is actually for us to see the intraorbital extensions of the infections as mentioned on the Canselor classification. So it's important to route all your cavernous sinus thrombosis, subarachnoid abscess, and also orbital abscess. We also can look for any intracranial source of infection with neuroimaging. Apart from that, we can sometimes there might be intraocular or cup foreign body which may not be obvious from the externally, then might presence upon imaging. So let's move on to the treatments. I think as illustrated in this case earlier on, so the treatments basically comprise of medical treatments and surgical treatments. So the medical treatments then will depends on the pathogens, and we give antibiotics or antifungals. Sometimes we give steroids and topical mydriatics for pain management. Then surgical management, we have vitrectomy and eviscerations. So first thing first, the antibiotics, we can give intravitreal antibiotics. Usually we prefer something broad spectrum. So basically we'll give vancomycin and also for term of ceftazidime. Then the other modes are the topical antibiotics. Also, we would prefer to give something broad spectrum, ceftazidime, vancomycin, gentamicin. Then the systemic antibiotics, we usually prefer to give the fluoroquinolones, which is ciprofloxacin, moxifloxacin, or even levofloxacin. The higher generation, the better. This is because of better ocular penetrations. We have to be reminded over here. The eye is actually similar to the central nervous system, in which you have your blood-brain barrier. The eye also have blood-retina barriers. So these blood-retina barriers are the major factors that impede all the penetrations of our antibiotics. So therefore, we usually will go for something with better ocular penetration, which usually is a fluoroquinolones. As for fungal infection, we can give intravitreal FOB, and then the newer agents were the voriconazole, caspofungin, topical anatomizing, intracanalols, and also systemic therapy such as fluconazole and flutaracin B. Sometimes we may give steroids. The steroids functions are basically to control the inflammations or mediated damage. But however, steroids must be used with caution. As mentioned earlier on, is relatively contraindication for fungal infection as well, because it may actually exacerbate the fungal infections. So now we jump off to surgical management. Surgical management basically is either eviscerations or vitrectomy. In cases of vitrectomy, usually we will perform in patients with better visual prognosis. So means their actually chances of recovery is better. So the advantage of the vitrectomy is actually basically to clear off the ocular media, reductions of the bacterial loads, removal of bacterial products, and then removal of all these vitreous scaffolding, which may cause retina detachment later on with fibrosis and so on. In cases in which we think the prognosis are very, very poor, such as in this case, in which the vision is already non-perceptions of light, the RPD is already very positive, then we know most likely there's no visual prognosis, and further on, very poor response to the antibiotics and so on, then we will perform eviscerations. These eviscerations is performed, as mentioned earlier on, also to prevent the intracranial spread of the pathogen, because you know the eye and the brain are so close to each other. So the next step is it may cause cavernous sinus thrombosis and cavernous sinus infections, and further spread to cause meningitis and so on. So this associated with very high mortality. So evisceration usually will be performed in these kind of cases with very poor prognosis. So as you can see, eviscerations are basically removing all the intraocular contents. If you remember my anatomy slides earlier on, basically to remove all the choroids and so on, so that together with this abscess. So as you can see over here, when we open the eye, the whole vitreous cavity is actually filled with abscess or pus. So that's why the removal are very important. Then we'll remove all the choroids, left with the sclera shell. So this is called eviscerations. Okay, then we'll suture up the sclera. Later on, we will apply ocular prosthesis. Okay, that's all. Thank you. Any questions so far? Any questions? If no questions, then we will go over to Kahoot. We have some Kahoot quiz. After the Kahoot quiz, then we will be showing the QR code for the CPD point. Can I have the multimedia Kahoot? Any questions in the meantime? So I think to conclude the sessions, it's very important for us to identify the serious causes of the red eye. So red eye is not just the normal conjunctivitis or whatsoever that you can just treat at home and whatsoever. So we need to know what are the serious causes, as mentioned earlier on the red flag symptoms. Okay, so the three symptoms which are the red flags. So you need to identify, and these symptoms are warrant urgent referrals to the ophthalmology. Okay. Also, then the other thing is regarding diabetes mellitus. Diabetes mellitus are very, very important, very essential to well control. So it's actually our responsibility to educate the publics on better control of the diabetes mellitus. Okay. Any questions in the meantime?
Thanks, Prof, for the question. So the question is whether we, in the hospital side, whether we need to take any precaution for the hypervirulent strain. For at least the data thankfully shows that the ability of the hypervirulent strain to pick up the most sinister resistance is less compared to the classical strain. The classical strain, the one, the nosocomial one, that one you have to be careful because that has the ability to pick up ESBL, CRE. Those are actually can be transmitted through doctor's hands. So, I mean, as a universal precaution, always wash your hands before and after touching the patients, but not this strain. This strain thankfully doesn't pick up strain. The only thing is we are colonized either through eating out and gastrointestinal tract, but it's not spread through nosocomially from one. Whether the classical one, yes, the one that you see ESBL, CRE. All right, thanks, Prof.
Dapat ke Kahoot?